Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Medicaid Update, Rural Health Clinics and Regional Care Organizations. If you have a question on anything that's being discussed today, please send an email or telephone call during our discussion. You now are seeing the phone number and email address on your screen that you can call into or email. And we will also have handouts available online. You have to be registered for the program in order to access the handouts. I'm Carolyn Byrne, Director of Community Affairs at the Alabama Department of Public Health, and I would like to welcome our faculty presenters today from the Alabama Medicaid Agency. Dr. Robert Moon, Chief Medical Officer and Deputy Commissioners, Drew Nelson, Project Development and Quality Assurance, Carolyn Miller, Associate Director for Project Development and Quality Improvement, and Jason Duhan, Consultant with Navigant. Welcome everyone, and now we will begin the program with Dr. Moon's presentation.
Right. Thank you, Carolyn. We appreciate it very much. We are very glad to have this opportunity to speak with the rural health centers and clinics to really review over where Medicaid is at in the implementation of regional care organizations, not only to review where we're at in implementation, but even to explain some of the background and concepts behind it. I have been in many conversations where I go to talk about RCOs, and almost invariably someone asks a question, what is an ROC or what is an RAC, as I was asked last week in a meeting in North Alabama. So I recognize that although many of you may be very familiar with the RCOs, others of you may not. And we're going to provide some basic information to start with to give some context to our discussions as they relate specifically to rural health clinics. So first of all, the actual program itself came about as the result of legislation. We didn't sit in a back room at Medicaid and sort of conceive of this idea. The state legislature, pursuant to actually a task force even before the legislation, pointed us in this direction and wanted to see the state Medicaid agency go in the direction of developing regional care organizations. And that's why we're here today. What's the difference? Why regional care organizations versus a typical managed care organization or HMO type organization? Well, these organizations are locally led. They're actually driven by providers in the region and local investor type folks by and large, although there are some exceptions to that, but they are locally led managed care organizations. They will be providing services for Medicaid clients. And again, it's a fairly broad-based set of services, and we're going to talk about that in just a bit. But when does it start? Well, it starts October the 1st of 2016 as far as when the regional care organizations will actually begin to pay for services and be responsible for services to clients. However, a lot of the work for implementing regional care organizations began actually a couple of years ago, soon after the passage of the law, the statute directing Medicaid in this region, and there has been a lot of work last year and much work going on right now to implement, and we'll talk more about that as we go forward. The state legislature was very interested in sharing risk. They wanted to have a partner to share risk with the state in operating the Medicaid program. So when you talk about regional care organizations, you're also talking about risk-bearing entities. So there is an upside, but there is a possibility of a downside. There is real risk involved in operating these organizations. The clients that will be involved or that the RCOs will be responsible for is fairly broad-based. You're going to see a lot of folks that are involved. I actually had someone ask a question not too long ago. What if I choose not to participate in regional care organizations? Can I still be a Medicaid provider? The answer to that is yes. However, you likely will not have many patients because most of the patients that we have will actually be in the RCO-led environment, and that's where the majority of Medicaid clients will be, particularly if you're a maternity provider or if you see children. A couple of key aspects to the regional care organization strategy. It will be a managed care system, albeit locally led. These managed care entities will receive a capitated payment. Now, the capitated payment is not exactly the same for every single member that gets assigned to an RCO. There are what are referred to as rate cells, so there will be different rates depending on simple demographic sorts of characteristics such as age or sex and a few other things, but there will be some differentiation. But at the end of the day, there is a capitated payment made to the managed care organization, and with that single payment from Medicaid, they will be responsible for the services for that client. By and large, most all of the services. There are some exceptions. There are some things that are out of their responsibility, but many of the typical services we think of recipients receiving, such as physician visits, hospital care, those kinds of things, the regional care organizations will be responsible to take that capitated payment and pay for those types of services. We'll see some more details about that as we go along. It is a requirement established in the statute that the RCOs be nonprofits. They are by requirement. A nonprofit organization, actually, it's established more in the administrative code, but there is a requirement that they be nonprofits, and that's what all of our RCOs are as we are now moving forward. They do have to have a board of directors. The boards of directors, the composition of those boards is delineated in the law that was passed to establish the RCOs, and it's very specific in terms of what types of individuals are represented on the boards of directors. RCOs are seen as a vehicle for transformation. By and large, Alabama Medicaid has, for the most part, been a fee-for-service environment. In recent years, we've had more management of clients through our maternity program, but also in more recent years, we've had more management of clients through our health home program. And this movement to the regional care organization will be even a improved or increased role of better management, or a better opportunity for better management of clients going forward. There will be a mandatory enrollment of clients into the regional care organization for the clients that are included, the types of groups of clients that are included, and we'll talk about that in just a minute, who actually fits into those assignments. The medical home, the health home, those types of models will continue to exist, not in exactly the same form they're in today, but the contract between Medicaid and the regional care organizations does require that they perform and follow typical sorts of medical home and health home requirements that the agency requires today, only in a little bit different format. So you will see things change, but you will also see some things that remain the same. As the slide mentions, it says it includes most Medicaid recipients. Really, we're looking at about 2/3 of Medicaid clients that will be inside the purview of the regional care organizations. And the regional care organizations will be responsible not only for physical health, but also behavioral health services. So let's talk about populations. The basic populations, again, result in being about 2/3 of our clients being in the regional care organizations. But to look more specifically, when you look at eligibility groups in Alabama Medicaid, one group is the aged, blind, and disabled category. Those individuals obviously would be in the RCO purview as opposed to others that might be out. Another program that's in, the breast and cervical cancer treatment program recipients. The MLIF category, basically adults that are involved as caretakers for children, they are in. And then probably the biggest single group is SOBRA children and adults. And obviously these are children, but also pregnant women. So when you think today about the typical Patient First program with over 600,000 recipients being involved in it, those folks will now be in the, now as of October 1, will be in the regional care organization world, as will individuals that are currently included in our maternity care program. Now, some people are out. Some people are out, as far as we know, for the foreseeable future. Others are out temporarily as the programs get the regional care organization programs get established. But these are the ones that are excluded. The dual eligibles, those individuals that are in your practices perhaps that have both Medicaid and Medicare coverage, they are out of the RCO populations, as are the others that are listed here. Foster children, hospice patients, the ICFMR recipients, the nursing home recipients, folks that would be in the nursing home today actually will fall into another managed care program that's just beginning to be developed called the Integrated Care Network. And that you'll hear more about that later. Again, state statute directing us to develop that program, but you will see more about that in the future. The other group that is out of, not included in the RCO populations is our Plan First population, those that have a level of eligibility that only entitles them to family planning services. That group of clients will be out, and then the home and community-based waiver services are recipients. Now, not only is there the division between which populations of people are in or out, there is a division of which services are in or out. And this begins to describe some of that when you look at services that will be covered by the RCOs. Obviously, as I mentioned earlier, hospital services and physician services will be included. It differentiates here in terms of mentioning emergency rooms, primary care, and specialty care. The federally qualified health centers, and yes, the rural health clinics will be included in the kinds of services that are provided by the RCOs. So there is going to be payment that will come through the RCOs to your clinics. We have Jason Duhan with us today to talk in a little bit about exactly how that will flow and exactly what will happen, but we have a detailed process for that where at the end of the day you would be made whole, but this will describe how that will happen, and we'll get into that a little bit later. Laboratory and radiology services will be included, as will these sort of behavioral health type services that are mentioned here. Again, a lot of specifics here, and these are just touching on some broad categories, but eye care and maternity care. So those of you that have been involved in the maternity care program will not be involved in the system as it exists today. You will be involved through the regional care organization starting October 1 of this year. We have to remind ourselves it's October 1 of this year. It's not some other year now. We're now in the current year. Other services to make mention of here, it says pharmacy is a Medicaid covered service, but it is actually not part of what the RCOs are responsible for. Also, long-term care and dental services are also not part of what the RCOs are responsible for. So the RCOs will not be paying pharmacy claims. They will not be paying for nursing home claims. They will not be paying for dental claims. Here are the basic regions. Some of you may have not seen these maps, but there are 5 regions. The state has been divided into 5 regions. There was a lot of discussion about how to divide these regions with an attempt to try to not cross any current care treatment, sort of typical referral patterns that are out there. Obviously, anywhere you put a line on the map, you're going to cross some of those lines. But the attempt was made to cross as few of them as possible. So ultimately, that was a driving force. The other driving force was looking at the size of the populations. One of the goals was to have a population in each region that was sufficient to support at least 2 regional care organizations. And that was one of our guiding principles in this process. So we ended up with these 5 regions that you see delineated on this map. Obviously, it was decided October 1/13 was when this map became final, so we've been working in this direction with this map since then. There are a variety of organizations that have reached a preliminary step in becoming fully certified regional care organizations. We have no fully certified regional care organizations today. We have 11 organizations that are on the path trying to become fully certified. Those 11 organizations today are called probationary regional care organizations, or probationarily certified regional care organizations. Those entities are working very hard to achieve full certification. And we'll talk a little bit about the steps that are involved in that. But to tell you who those probationary organizations are today, we have a series of slides. And in Region A, and just as a reminder, this is the region across the northern tier of Alabama, currently there are 3 probationary RCOs. And it sort of mentions here a little bit about who some of the major partners are that are involved in those groups, and you can read those for yourselves. The development of these different groups has been a long process, and sometimes you see some of the partners change and whatnot, but the ones you see today are, to my knowledge, are current with what we have, that we have knowledge of at this point. Again, this is Region A. There are actually 3 probationary RCOs in Region A. Currently, only 2 of those organizations are providing health home services, but there are 3 probationary RCOs in that region. In Region B, there are 2. Every other region except A has 2 as it stands today. And again, you see those 2 here, and you see who the sort of major partners are that are involved in the 2 organizations in Region B. And this is primarily in the Birmingham region and east of there. Region C is in West Alabama. Think about the Tuscaloosa area and west over toward Mississippi. There are 2 regions there. 2 probationary RCOs there, and you sort of see the partners that are listed on this slide. Region D, think about Montgomery, Dothan, the sort of southeast region of the state. And again, we have 2 partners that are 2 probationary RCOs here, and their major partners are listed on this slide. And then finally, Region E, the southwest area of Alabama, obviously Mobile, the major city there, but several other counties that are involved in that region. And you'll see here the 2 probationary RCOs that are listed for that region, and that are both pursuing becoming fully certified RCOs. So it's very possible that you might have heard from all 11 of these as they've sought to obtain letters of intent in their process of developing and trying to meet the criteria that have been established by Medicaid, and the Medicaid criteria are reflective of CMS, or the federal government's requirements for managed care organizations and what kinds of requirements they have to meet. Here are the key dates. I mentioned earlier that the probationary organizations are striving to become fully certified. There are lots and lots of things they have to do, but there are 3 big steps, 3 big hoops to go through. One of these hoops is the development of an adequate service delivery network. Do they have enough providers? Do they have enough hospitals, enough labs, enough, all of those kinds of things that are listed there? It mentions here April 1st was the time they were to submit information. All of them did submit information. We were able to continue to take information from them about their networks for a few months after that. And the final decision about all 11 of those organizations is yet to be determined, but hopefully we'll be hearing in the near future a final decision on all 11 of the organizations to understand who made it, who didn't make it, or whatever. But that is one key hoop. Another key hoop to go through is solvency. Do they have enough money to do what is being required of them? Do they have enough money to take on this type of risk? And the requirements for how much money was established in the law that was passed by our legislature and signed by the governor, and they're all in the process of meeting those requirements. So, and then finally, and I actually got into a discussion about this yesterday a little bit with someone, how will Medicaid make sure that these organizations can really do what we've asked them to do? And there is an extensive readiness review process. The readiness review is based on the contents of the contract between Medicaid and the RCOs. That contract is really based on the state statute and on the federal rules and regs associated with managed care. So there is a naturally evolving process, but at the end of the day, there will be a readiness review, an actual review of what the plan is that each of these organizations has to deliver care in their region and to be responsible for it. There is an extensive work plan that they've all submitted already. We've already made some comments on them. They will resubmit additional information. We will review some things at a desk, but there will actually be an on-site visit by Medicaid and some of our consultants. And at this point, we think even CMS, the federal government, will come on-site with us to look at each organization that is pursuing full certification to review, can they actually do what they've proposed to do. A lot of things happen in parallel. We've talked a bit about the RCOs. We've talked a little bit about the contract. But in parallel with this is what is termed by the federal government 1115 waiver. Basically, this is the state's attempt to ask the federal government, would you give us the authority to do what we're talking about doing in reorganizing care and improving the system? And oh, by the way, there's also a request for additional funding that the 1115 waiver can make available to the state to be able to pursue these types of initiatives. There has been a lot of progress made on that, and we actually, every time we think we're done, we're not quite done, according to the federal government, but we do have good reason to think that we are very close right now to having final approval, and we hope that that's going to be true in weeks, not months. But until it's final, it's not final. But that waiver is very important to this work, both in terms of giving us the authorities to do this kind of work, but also giving us additional funds. It does describe, and it describes here some of the key components in terms of a case management system of coordinated care, and you're going to hear a bit more about that from Carolyn Miller in just a bit. It describes another feature of this is having adequate access and helping with that access, and there will be some initiatives associated with that relative to the 1115 waiver. And then, one of the key tenets would be that it would be a cost-effective process. Even one of the requirements in the state law is that this be cost-effective, but certainly the federal government would envision us being able to do this without spending any more money than we would have otherwise spent. And then ultimately, the raising of overall health of Medicaid beneficiaries is important to all of us. It's important at the Medicaid agency. It's certainly important at your clinics. But it's also very important to the federal government. They have tied a lot of the funding associated with this waiver with various quality outcomes. How will they release the money will be contingent upon performance on various quality outcomes, and it's a very pertinent part of what we're talking about. Again, this will be involved in developing the infrastructure necessary to do all of this, and hopefully, again, some stability and predictability to the state funding requirement for Medicaid. Remember, at the very beginning, what the legislature wanted to do was to help share some of the risk involved in operating the Medicaid program. There will be a requirement for a lot of coordination amongst different providers, and that can actually be a very good thing in the sense of getting better, more coordinated care that is more synergistic in terms of what it can achieve. Healthcare is different in different regions, and it may be that some of the issues you deal with in one region of the state are very different from issues in another region of the state. This will be a more locally led initiative to be able to adapt to some of those to those local needs and requirements. It says here providers must contract with at least one RCO in order to be paid for services and may contract with multiple RCOs. Again, there will be a small component of Medicaid's business that would still be fee-for-service, as we've talked about earlier, but it would be small because the majority of our populations will be in the RCOs. So if you want to be part of having access to that larger population of patients, then you would want to participate with the RCOs. And obviously, if you choose to participate with more than one, that's up to you. I mean, that's certainly your option. You may think of that as an advantage to you, or you may not want to do that, but it would be your option to be able to do that. There are some protections in the law that are meaningful, one being the any willing provider rule that's part of the law. It basically says similarly situated providers have to be offered a contract with the RCOs, and if they're willing to accept the same terms and conditions of similarly set providers, then you have to be offered the contract, and you have the opportunity to participate. The other requirement is how much do you get paid, and the law establishes that no one can be paid less than the prevailing fee-for-service rate. So what is prevailing at that time? Not what the fee-for-service rate is today, but what it might be in the future. So that will be an important consideration going forward also. In your situation, you have a different payment methodology, and Jason will talk about that in a bit. Obviously, your reimbursement is protected in the sense of federal rules and regs around that. And then finally, it mentions that the prior authorizations and the referrals that they're going to utilize can't be more restrictive than what the current Medicaid program's restrictions are. It could be less, but it cannot be any more restrictive than that. And then it mentions the provider contracts have to be approved by Medicaid. Certainly, at least some of the key elements of those contracts would have to be approved by Medicaid. And then nurse practitioners may participate via a supervising physician. EPSDT, a federal requirement, they may utilize a different process to actually get things approved via EPSDT, but the requirements must be met. And again, because we're talking about different organizations, you may see some different looking forms as things go forward, and that's, again, just part of doing this sort of business. And then it mentions specifically that the RHCs are eligible to participate as providers and will receive wraparound payments. And again, we'll get back to that in a bit. And then it mentions the service delivery networks and that community mental health centers will be involved. The contract requires the use of community mental health services for the rehab services that they provide. You likely would see the community mental health centers and other types of other providers of behavioral health services that would exist for other than rehab services. That really concludes my part. I know we'll have some time at the end to be able to answer some questions, but now I'm going to turn this over to Drew Nelson to talk about some of the other aspects of implementing the RCO process.
Thank you, Dr. Mann. One of the things that we've had a lot of questions about as we met with a lot of different provider groups was the issue about how we do the enrollment, not only to the RCOs, but also to the PMP. A lot of y'all are currently participating in the patient first population in the program, where Medicaid not only rules someone as ineligible for Medicaid, but then assigns them to a PMP through an assignment process, so they actually get assigned directly to the PMP. It'll be slightly different in the RCO. Moving towards the RCO, there'll be two levels of selection. The first will be the selection of the RCO by the enrollment broker, or the assignment of an RCO by the HP. Initially, we will go with the enrollee. The enrollment broker is basically a non-biased third-party entity that does outreach counseling to all of our recipients to help advise them between the different RCOs within their region. One thing that is a big difference from the previous Medicaid program and moving towards the RCO is that we will be assigning people to an RCO based off of the county of their residence and not the county and where the provider participates. That's a big difference for a lot of our providers. The second level of the assignment process occurs within the RCO. Once Medicaid assigns an eligible person to a specific to the RCO, that RCO will then have their own algorithm, much like Medicaid currently does now, to assign that eligible person to a PMP, or primary care provider. That process will be managed by the RCOs, but we are working with them to try and understand their algorithms and to work with them, so we do a lot of outreach along with that. Because the patient first assignment process will be ending, as the patient first program will be ending, the last assignment that Medicaid will do for the patient first population will occur in August of 2016 for the September 2016 month. After September 30th, the program will end in October 1 of 2016 this year. The RCOs will take over that enrollment. So again, we do have two different levels. Medicaid currently are focusing on the top level, where we will actually assign working with the recipients between RCOs. It'll be up to the RCOs, and we actually encourage you to reach out to all the RCOs and to start discussing with them to understand their enrollment process amongst their PMP networks. There will be some PMPs that will be they'll only sign up with one RCO, and that is their right. And then there will be other PMPs who will sign up with every RCO, and that's also their right to do that. Where we think they'll have a lot of issues will be between those PMPs that only choose to sign up with one RCO, so they could lose some of their current panels that way. So again, the enrollment process, we will begin in July of 2016, doing a lot of outreach. We'll go through August 28th, 2016. This is for the initial assignment process, for the initial when RCOs go live. We will always have this enrollment process going forward because we have people who lose eligibility and then roll back into Medicaid. They might come out of the RCO program, but then, say for instance, they go into long-term care. Once they leave long-term care and they're eligible again for the RCO process, they'll go back into the RCO program. We also have new people who are enrolling to Medicaid, so they will also have to be assigned. But during this late summer, we'll do an extensive outreach that will be planned to encourage our recipients to go out and work with and choose their own RCO, because that is the number one priority for Medicaid, is that our recipients are actually choosing the RCO that they choose and they will want to work with. That's really what the enrollment broker will be doing. They'll be providing a lot of different information to our recipients, trying to help encourage them and educate them in the selection between the different RCOs. Then once they are assigned to an RCO, that RCO will do outreach with that recipient to really help encourage them to make an active selection to a PMP. It will be then those enrollees who've been contacted by the RCO, who have been assigned to that RCO but have not chosen a PMP that they would like to be assigned to, the RCO will assign them to a PMP. So let's talk about the enrollment broker. Like I said previously, they are a non-biased third-party entity outside of Medicaid and outside the RCOs. Medicaid will have a statewide contract for the enrollment broker for now until currently we're working on a 5-year contract, but it will be in perpetuity. What the enrollment broker will have a list of all of the providers that is in every RCO's network, so RCOX. They will provide to the enrollment broker every PMP, every hospital, every core specialist, every non-core specialist, everyone that they have contracted to provide care to. They will also have the basic benefit services, so all the services that Medicaid currently provides, but the RCO also has the ability to expand and provide additional coverage services. For instance, diabetes self-management education. It's not currently a covered service by Medicaid, but an RCO might choose to provide that services for their diabetic population. Those additional services would be identified by the enrollment broker and be shared to the enrollee. They will also have clinical history from Medicaid saying, we know that you currently are assigned to this PMP. We currently know that you have been seeking care from these providers, and these providers are either signed up with both RCOs within your region or only signed up with one RCO within a region. So all of this information is really provided to that enrollee so that we hope to have that enrollee make their own active selection. That outreach can occur by telephone, via mail, by in-person counseling, all of the different types of communication we are trying to use to really have as many of our enrollees make an active selection to which RCO they want to choose. Once the enrollment broker has made contact with that recipient and that recipient has made a selection, that selection will be sent over to HP, and HP will go on and send within 24 hours to that RCO saying that X recipient has now selected your RCO. You need to go on and do some outreach, including welcome to the RCO, here's the services that we'll provide for you, but also here are the PMPs that you have to make a selection, and you need to go on and start working towards selecting who you want as your primary care provider within our RCO's network. Once the enrollee has selected an RCO, they do have 90 days to choose to switch to the other RCO. So say for Region B, where we have 2 RCOs, the recipient might choose to say, we want to go with RCO X. After 90 days, meeting with their PMP, seeing the services, whatever their outreach might be with a care coordinator, they might have the choice and say, you know, I should have chosen that other RCO. I think I'd be better over there. It is the recipient's ability to choose to switch to the other RCO at least once during the first 90 days of selection. After that first 90 days after October 1 of 16, that recipient will be locked into that RCO for the rest of their year. Now, they do have an open enrollment period like entity every year. So every year they do have a period where, just like we do now with private insurance, if you have a choice of switching insurance companies once a year, that recipient will be able to choose to select a different RCO within their region. But that selection is limited to those RCOs that are certified to provide care for that region. If that recipient lives in Region B, they may not choose an RCO who lives or who operates in another region. It is limited to where they currently reside. Again, going back to PMP selection, though, how we currently do the selection right now in the patient-first population to actual PMP, that process will now be determined by each RCO. So each RCO might have a different algorithm and might take into different consideration how they assign their enrollees to PMPs. They might take into consideration the number of providers they currently have in that network, the services provided by that PMP, how close that recipient is to that PMP's office, and how often that PMP is at the different clinic locations. So those type of information, we do encourage you to reach out to the RCOs and ask them as you start working with them and signing letters of intent and your contracting period, all those type of information. Panel size. Currently, because the panels, a lot of our providers might sign up with multiple different RCOs, particularly if you happen to have a practice that is right on the border between different regions, you might want to sign up with every RCO in both of those regions that you're bordering. There's a lot of different information with the panel size, and it's hard to maintain, well, I have 20 over here, I have 100 over here, 250 with this other one. We know that's very hard. And currently we are working to try and make a recommendation to alter the contract slightly to allow the RCOs maximal flexibility in being able to manage their own panel size, because it is a very large administrative burden. We also want to make sure that the recipients are receiving the minimum services determined. Any service that is currently being performed by Medicaid, any of our basic services, every RCO must provide those services. They can't reduce any services in their scope of business. But they, like I said previously, they can expand those services. Smoking cessation, if they want to do above and beyond what Medicaid currently allows. If they want to remove the 14 visits per person per year, they can remove those type of services as well. And a lot of our RCOs are discussing looking at removing some of those to provide more primary care for our providers. But again, it is up to each RCO, and the RCO has to allow and get approval from the Medicaid agency to expand those services. And those additional services and benefits, we would be working with our recipients through the enrollment broker so that they understand those services. So I know this is a very squished up slide. We did provide this, they said, as a PDF. What this is a very detailed algorithm process of how Medicaid will go through in determining our recipients and the assignment process. This, again, only focuses on the assignment of a Medicaid eligible person to an RCO, not within that RCOs. Again, Medicaid will determine eligibility. Once we determine someone is eligible for Medicaid and that they are eligible for an RCO service, we will send that file to our enrollment broker. We will send monthly files to the enrollment broker and also daily files to the enrollment broker. So for instance, if you earn eligibility today, we will send your file today to the enrollment broker so they can go on and do as quick as outreach as they can to that enrollee. We have about a 30-day window where that enrollment broker will be doing outreach to that recipient. They'll send out a letter saying, congratulations, you're now eligible for Medicaid service, you're now eligible for RCO services. You need to make a determination of what RCO you would like to do. We are still working out all those details, and we'll be able to and be happy to share those details, how the enrollment program process will work once we finalize all of that. Ideally, the number one priority in selecting an RCO is we do want the enrollee to have first choice. That's a big component for not only CMS but also for Medicaid. We want our recipients to have a more active role in choosing the care that they seek, and we want them to choose the RCO that they want to operate within. Medicaid at the same time will provide clinical history to the enrollee or to the enrollment broker. We will analyze all of the care that enrollee has sought within the last 3 years. Have they been assigned and consistently been seeing a PMP, or are they seeking ongoing care with an oncologist or another type of specialist, where we really think that because of how the specialists have signed up with their RCOs, we really need to make a recommendation that that recipient be assigned to a RCO. So that enrollment broker will have that information and say, John Doe, you have actually been seeing this PMP every 6 months for the last 3 years, and your PMP has only signed up or chosen to sign up with one RCO. So if you choose to seek care with that PMP continuously, you need to be aware of that, and you might want to go with this RCO over the other. Now, it is the recipient's choice. If they say, I know I've been seeing this doctor, but I think I might want to change, and they choose to go another RCO, that is their right, and we will allow that. But again, once that enrollee goes to that new RCO, they do have that choice to switch back to the other RCO once within the first 90 days. Hopefully, like I said, we'll have all of our enrollees make that selection process actively. Once they make that selection within 24 hours, the enrollment broker will let HP know that that person has chosen an RCO, and HP will, within 24 hours of that selection and notice, send it to the RCO and say, John Doe is a new Medicaid enrollee, and they have chosen to seek your services through your RCO. You need to begin your outreach work. That will include doing initial health assignments, health assessments. We'll also be doing PMP assignments within that RCO. But once they've been assigned to that RCO, that is as far as Medicaid's process will go. Because Medicaid enrollees tend to be hard to reach, they might have moved, they might not be able to come in and make an active selection, or they might not just choose to make a selection through the enrollment broker. What Medicaid will do next is taking all of that clinical history and looking and analyzing all of the networks within that recipient's region. So we look and say, okay, we'll stay with Region B as just an example. You're a recipient in Region B. You have been seeking care with these specialists and these PMPs within the last 3 years. Well, your providers have signed up with both RCOs within your region, so therefore there is no distinction that we cause no harm if we push you or we make a selection between either RCO. So we would move that recipient on through to the process for an auto assignment, a true auto assignment. Now, for those eligible recipients who there is a statistically difference between the two networks, and we might cause harm to that recipient by not putting him in one RCO over the other, we will make that selection through their clinical history and through their current medical preference for one RCO over the other. We believe that will be no more than 25% of any population in any of our regions. Once Medicaid does say this recipient needs to be with this RCO because of their clinical history, we will notify HP, and HP will also notify the RCO this person has been assigned to you. But a vast majority of our population, because of our networks and because of what we are seeing right now in the network development, there is no distinction between the two networks, or they just don't have a clinical history where there is a difference between the two RCOs. We will go through an auto assignment process. At the beginning, because no one has a clinical history with an RCO, we will skip step one. Step one, as we move forward after initial selection, is has that person been in an RCO previously? Let's say, for an instance, we have a lot of people who are in the RCO program, they're in Medicaid, and they might lose eligibility for a couple months. Well, in the RCO world, if they lose eligibility, come back on the Medicaid eligibility system, and we notice that they were previously assigned to RCOX, we will go on and automatically sign them back to RCOX because there is that continuity of care there. But because of the initial selection, there is no history with any of the RCOs. We will move next to what is their family members. Has any of their family members or held a household, have they made a selection? Through our clinical history, we might have a special needs child who has been seeking care with a lot of PMPs and specialists, and because of the continuity of care and because we want to provide the continuity of care for our recipients, Medicaid might have made that selection for that recipient to go with one RCO. Because we want to keep families together whenever possible, we would say then for all of their siblings or anyone else within that family, we would also assign that their family members to that RCO. Through the enrollment broker, a mother might come in and say, for this child, I know they have a lot of health concerns, I want to make a selection for that child alone. They may not make a selection for their own care. Well, if that's what we see, we will go on and assign the rest of that family to an RCO. The mother could also at the same time say, for these two kids, I want this RCO, and for myself and this third child, I want to go to this RCO. Well, because it is a recipient's choice to divide amongst an RCO, we are not going to correct that. We will allow the recipient to choose between and have care between the two different RCOs. Half their family go with one RCO, the rest of the members go with the other RCO. After we go through previous assignment, clinical history, whether their family members are in with an RCO or not, the last choice is we will have a risk assignment, a risk score for all of our recipients with a clinical history. And what we will do is we will divide the rest of the recipients through an auto selection process evenly. Not so much a one-to-one, but an even distribution of risk amongst the different RCOs within a region. What we are trying to provide is an even distribution, where possible, of risk and numbers within the different RCOs. We don't want to set up any RCO where they have so few of a population or such a high risk within their population that they become actuarially unsound and would not be able to be financially, physically able to continue on. We want all of our RCOs to succeed wherever possible. Now, if one RCO happens through choice and recipient's choice to have a much higher number of a population than the other RCO, we will not correct for that, because that is a recipient's choice. Again, recipient's choice is our #1 priority in the selection process. I know there was a lot of details, and we have tried to provide a lot of not only our guiding principles, but some of the information that we are providing to our enrollment broker all in this video. So please take some time to look at that. And if you ever have any questions about that, please, we will give you an email address after this presentation that you can email us, and we'll be happy to answer those questions. So then, again, this whole process was just the selection amongst RCOs. Now we need to talk about the PMP selection process. PMPs will need to really, we're entrusting you, you get to choose as a provider who you want to contract with. Do you only want to select one RCO over the other? Do you want to contract with every RCO that you can possibly do? That is your right under the Any Willing Providers clause. If you happen to have a clinic that is on a border between two different RCO regions, you might want to contract with multiple RCOs in different regions so that you try and encourage your panel size. But what we want to encourage you to do is, if you choose to only sign up with 1 or 2 RCOs, we want to let you know that it's on you to really encourage and inform your panels and your patients who you've decided to see. If you have a large panel size and you want to maintain as many of your patients as possible, and you choose to only sign up with 1 RCO, you really need to let your patients know that I have chosen to only sign up with RCO X, and if you want to continue to seek care with me, you need to make sure when you go through the active selection, you choose RCO X to stay with me. But because of that, some PMP panels may not stay intact. You might lose some patients, you might gain some more patients. And there's several reasons for that. One, like I said, if you've chosen to only sign up with 1 or 2 RCOs when you have the ability to sign up with multiple RCOs, you might limit those patients. If that patient chooses to sign up with that other RCO, therefore they will have to have a new PMP. They also might be living in a different region, particularly, like I said, if in your border area and you've only chosen to sign up with the RCOs that are operating within your region that your clinic is currently located. Because your recipient might live in another region, they would have to seek a provider that's within their region. Also, if a recipient doesn't choose an RCO, the auto-assignment process will look to see if the household has chosen an RCO. They might have chosen a different RCO. You might consider them your patient. They're on your panel. You've had a history with that patient, but you might not have seen them in 3 years, or you've only seen them once in the last 3 years. When we do our clinical history and analysis, there's really no difference in the 2 networks when we only see 1 or 2 visits for that recipient. And if you haven't done that outreach with your patients, and they have not actively chosen an RCO to stay with you, then because of that, we might have those recipients be assigned to another RCO or to another PMP. So we do want to make sure you're aware. The biggest key takeaway here is please be educating your panels, your patients, and your panel sizes with who you are going with and what you're deciding. Again, patient choice does drive the RCO selection process. It is #1 priority in all of our process. We are giving an active selection process through the enrollment broker. If no choice is made through the enrollment broker, they are going through an indirect active selection through the clinical history through Medicaid's analysis. And then if all of those are exhausted and we still have not made a selection, or if there's no distinction between the RCOs, we will go through an auto-assignment process that matches much like we do currently in the patient-first population. But again, it is only a selection to an RCO, not within RCO to a PMP. Each RCO controls that process for the assignment within a PMP. Again, like I've spoken about previously, PMPs, onboarding regions, we do encourage you to sign up with multiple RCOs within all regions that you border. Again, the RCO assignment process is not based off of where your practice is and where you currently practice, but is where the recipient resides, the county of their residence. And the recipients must be eligible for Medicaid and be eligible for the RCO program at the time of enrollment and assignment to be assigned. So next we will go on some billing issues to Jason.
Thank you, Drew. My name is Jason Duhan, and I work with Navigant Consulting. We've been assisting the agency with the transition over to RCOs. So first, we want to talk to you about how RCOs will pay rural health clinics and also FQHCs. Per the contract, that's going to be paid at the physician fee schedule. The current physician fee schedule is posted on the AMA website, so you can take a look at that. However, there will be a difference between what that fee schedule has and what your current rate is with Medicaid. And the agency will pay a wraparound payment to make you whole. So you will receive the same payment, it's just going to look a little bit different. The reason why that wraparound payment is there is mandated in federal law per sections 1902 and 1903 of the Social Security Act. So that's why that wraparound is going to be in effect. So what is that going to look like? AMA is implementing a solution that's going to allow you to submit claims directly to HP to get reimbursed. Other states have a quarterly wraparound payment where the MCOs will report which FQHCs or RHCs received services and how much they got paid. That's a little bit slower to get the payment back out, so this is really going to hasten that payment back to you. That process will not be available on the first day. It's not going to be available on October 1st. That's going to be the #1 priority after October 1st and will be implemented in the first quarter of 2017. So for that time period between October 1st and first quarter of 2017, AMA is working on an interim solution that will make you whole fairly quickly like the new solution will. So having said that, I also have a diagram here. I'm going to kind of talk you through this. What it shows here, there are kind of three major players. The RCO, the FQHC or RHC. It says FQHC on here, but the FQHC and RHC reimbursement process is exactly the same. And then AMA and their fiscal agent, HP. So the first thing that would happen is a member present for services exactly like that happens now. The RHC, FQHC is going to provide the services, and then a claim will be submitted to the RCO. The RCO is going to calculate the payment, and that payment, like I said, is going to be based upon the current physician fee schedule. The payment will go back to the FQHC or RHC, and then that organization will also send a claim into AMA or HP, the fiscal agent. And that process is already currently occurring. You're already submitting claims to HP, so it's going to be very similar. The main difference is any type of payment that you have submitted or reimbursed from the RCO, you will include as a TPL payment. That's going to reduce the amount from your current rate. So you'll get the current rate minus how much was reimbursed through the RCO, and that difference is what's going to be paid back to you. So I have a small example here, which is if the RHC submitted a service, I just picked one, 99213, to the RCO, it would pay per the physician fee schedule. Right now, that's $43. If the FQHC or RHC, whenever that submits that claim in, you would submit that you got paid that amount as a TPL amount. So if your rate was $163, it would be $163 minus the $43 that you already received, and AMA will send out $120 payment. So if your rate is $163, you got paid $163. The only difference is you had to submit the claim first to the RCO. So there are other states who have implemented this strategy. Ohio is one of them. They had implemented previously a strategy of the quarterly payments. That was something that it took a little bit longer to get the payments back out to the FQHC, RHCs. Typically how that would work is for the quarter, the MCO or RCO would submit 30 days afterwards to say how how much services were rendered. So that could be, it takes you up to 4 months to get paid. With this strategy, that payment is going to come into you much, much faster. So this is generally how the reimbursement will flow through to you.
Thanks, Jason. I'm Carolyn Miller, and I've been working with the health homes and the care coordination services through this transition. Care coordination is going to be a very large part of the regional care organizations going forward, and that actually started last year. But as per the contract that we are working with the regional care organizations on now, the RCOs must provide care coordination services to the following areas. First of all, it has to continue with our health home program, which I'll be discussing in a few slides further on. But that is basically for those recipients with chronic conditions and behavioral health diagnoses. Another population which the care coordination services have to be provided to is the actual general population. So basically everyone who comes into the regional care organizations could possibly have a care coordinator. So anyone in need of care coordination services will have those services available to them in all of our regional care organizations. And then last but not least, all those recipients that are pregnant must have a care coordinator just as they do today through our maternity care program, except now it will be overseen by the regional care organizations. Our health home program has been an interim step as we go forward with the regional care organizations. The health homes were started by what you may remember as the Patient Care Networks of Alabama. This was 3 to 4 years ago that we implemented this through 4 geographical areas as a pilot program. It was in Tuscaloosa, Huntsville, the Opelika-Auburn area, as well as Mobile. Well, last year, it was almost a year ago, we expanded that program statewide. It's called Health Homes because that's what the federal government calls it. This is not a home health program. We get that question quite often, but this is for the health homes. Starting in April 1st of 2015, when we went statewide, we made the requirement that the probationary RCOs had to be the ones that oversaw the program. This is to help them to build their networks, to help understand that capitation payment, and to help with their implementation as a regional care organization and be ready this year in October 1. So only the probationary RCOs were allowed to respond to our health home RFP. Of our 11 organizations, 6 of our probationary regional care organizations are providing services. If you remember our 5 regional areas, there are 2 health homes in Region A, and then each of the other 4 regions have 1 health home each at this time. However, when the RCOs go live on October 1 of this year, all of them will have to be providing services to our health home program. To help you understand the timeline of this, because we have 2 things going on in tandem with our health home program and with the RCO programs. Right now with the health home programs, of course, the probationary RCOs are managing that program, and that impacts only the PMPs, the patient first providers that we have. As we go into the RCO program, of course, all of our medical physicians will be impacted by that. But right now with the health home program, only our PMPs are contracted to assist in the health home program and provide health home services to their recipients. The go live date of that, as I mentioned earlier, was April 1st, whereas with the RCO program, their go live date is October 1 of 2016. Both involve the probationary RCOs, except right now it's probationary RCOs, and then of course I was about to say next year, Dr. Moon, but it is this year. October 1 of 2016, it'll be the regional care organizations. The program objective for the health home program is to build that case management services statewide so that the RCOs are ready to take on those other 2 populations going forward of the maternity and the care coordination for the general population. and to integrate those services with what they will be doing when they become full risk organizations. So let's talk about the health homes for a minute. I hope that many of you are already participating in this program. If you aren't, you can go ahead and sign a contract with the health homes going forward, and I hope that you can see that there are some wonderful benefits to you as a provider in the health home program. The health home program's emphasis is on providing care coordination for those with chronic conditions or with a behavioral health diagnosis, and is to integrate the medical services with those behavioral health services. For a patient to qualify, they have to have 2 chronic conditions that are listed here, or 1 chronic condition and being at risk for another, or they have to have a behavioral health diagnosis. Until April 1st of this year, we had all of these diagnoses except for hepatitis C, and that was added this past year as one of our chronic conditions. So you can see we cover a lot of chronic conditions in our health home program. The health home program is set up to provide an additional level of support for our PMPs. This service is for the general population, as I mentioned, going forward on October 1 of 2016. But it provides our PMPs a care coordinator. They can come into your practice. They can provide those services to your recipients right now who qualify for these conditions. I'm going to be speaking about the services that we provide for the health homes, but going forward, these services will be covered under our general population as well. The maternity population will be a little bit different than this, but these are the care coordination services that we currently provide under health homes and that we will continue to provide to them as well as the general population when the RCOs go full risk in October. First, we have our care coordinators that can be nurses or licensed social workers. They meet with the recipients one-on-one, face-to-face, to determine what are their strengths, what are their needs, what are the obstacles that are keeping them from having a healthy life, and managing those chronic conditions or those behavioral health challenges that they have, helping them to develop a care plan so they can address those needs, those barriers to care, and provide the resources available to them. They can meet with recipients anywhere. They can meet with them in the home. They can come to your rural health clinic, meet with them there as they come and see you. I've had recipients that when I've heard about that when they called to make a face-to-face visit, they didn't want to meet them at home. They wanted to meet them in the parking lot at the Piggly Wiggly around the corner. They weren't comfortable with the care coordinator coming to their home. So they met with them in the parking lot of the Piggly Wiggly. Sometimes it's McDonald's. It's wherever the recipient wants to meet with that care coordinator. So the care coordinators want to be where they are most comfortable in helping them to meet. And then they meet with them regularly. They provide them the resources that they need going forward. There's no time limit as to how long a recipient has a care coordinator. It may be for a week or so. It could be for 2 to 3 years. It depends on what is going on with that recipient. So they can work with your patients as long as they need to receive care coordination. It may come to a point where you are discharging a patient from care coordination services. They need them a few months down the road. Of course, they can pick that up and see that client again. Transitional care services. This is not something you traditionally have seen in Alabama. And it's one of the programs that I'm very excited about that has been implemented through our health home program but will continue with the general population. It is for those recipients that are in some type of inpatient setting. It's usually the hospital, but it could be a behavioral health inpatient facility or a rehabilitation center and so forth, where the health home care coordinators or the transitional care or the RCO care coordinators going forward will go to the hospital, work with that recipient as well as the discharge planners in the hospital to see what that recipient needs when they go home. I used to work many, many years ago as a discharge planner in a large medical facility. And we would work with the patients there, we would work with the doctors, the hospitals. But once they were discharged from the hospital, we didn't know what was going to happen. We ordered home health, we ordered the equipment, but we weren't sure what was going to happen when they go home. Well, this takes that another step forward in that our transitional care nurses and our social workers will go to the home where the recipient has now gone to make sure they understand how to use that equipment, that they've gotten the prescriptions that they need, and that they have the resources that they need so that they do not have to be readmitted to the hospital anytime soon and can continue to recuperate from whatever condition that they have. The transitional care program is not to replace those discharge planners, but is only to enhance the services as that recipient is transitioning back into the community. Another program that we have is that we have pharmacists that will be on staff with the regional care organizations, and they are currently on staff with our health homes. These pharmacists do medication reconciliations when they need to. They educate the recipients about their prescriptions, or they work with the care coordinators and the transitional care nurses to make sure those recipients know what type of medications they're on, what type of problems they might have, any adverse reactions they would have with other medications. They also work with the physicians, with you in the rural health clinics. We may see that from a claim the patient is on a medication you may not know about. So we can alert you to that and make sure you understand what your recipient is on. They also work closely with our inpatient medical facilities. As you know, some of our medical facilities, your recipients are being seen by hospitalists. And sometimes hospitalists aren't well informed on what medications Medicaid will pay for. And so the pharmacist can work with that hospitalist to make sure that the recipient is on the proper medications and can get those once they leave the hospital. So those are the services that are provided currently with the Health Home Program, but will also continue with the Health Home Program as well as the general population in October. So how does the Health Home Program benefit you now, and how will it benefit you in the future? First of all, you will have access to those transitional care nurses as well as the care coordinators. Many of our care coordinators are actually embedded into doctors' offices, physicians' practices. They could come to the rural health clinic and be part of your staff there. And the nice thing is you wouldn't have to pay for it. That is covered through the Health Home Program and through your Probationary Regional Care Organization. Think about it. If you needed a social worker to see one of your clients and you had someone right there that could just walk down the hall and see that recipient, it can certainly enhance your practice. You would have access to those transitional care nurses as well as the pharmacist. So that is one benefit that you would have as a rural health clinic if you're participating in our health homes and working with the RCOs going forward. Another is increasing your network of regional providers and finding out what is effective in each of the medical practices. As part of the health homes, you're required to attend regional medical management meetings. If you are in one health home, you have to go to at least 3 medical management meetings a year. Oftentimes they're in the evening, and then participate in a webcast with that health home. If you signed up for more than one health home, which is a possibility, you won't have to go to 8 meetings. You would still have to only go to 3 and participate in that webcast. It's a question we get quite often, and we know your time is very precious to you. So we wanted to make sure that you attended those medical management meetings, but not have to go to quite so many if you are assigned to more than one health home. But during those medical management meetings, you would learn the data that we're looking at is, as you know, with the regional care organizations, we are very much data-driven in how we will be looking at quality, how we will be developing health initiatives going forward. So you can see what's happening in Mobile, what's happening in your West Alabama community. Are asthma-related emergency room visits on the rise? Is there something we need to do there? Are people not coming in for their EPSDTs? So you would find out what are those issues that are important to you. But it also helps you share with other practices. Maybe you are doing a great job on immunizations, EPSDTs. Well, the other physicians in the area would like to know how you have been so successful in that. So it's a sharing of the group with that. The other benefit to you, again, is additional time. Instead of your staff having to track down recipients if they haven't come in for their appointments, you could reach out to your regional care organizations and the care coordinators to try to find your recipients, make sure they're following up with their referrals, and making sure that they are following the medical regimen that you've set forth. So there are a lot of benefits to the care coordination, not only with the health homes now, but in the future. So what are the qualifications to become a care coordinator? Not anyone can be a care coordinator. There are certainly qualifications to that. The care coordinators must be licensed social workers, or they must have a bachelor's degree in nursing. We do have some waivers that, for some of our areas that had difficulty finding BSNs in their region, we have some care coordinators that are RNs, but they must have a significant amount of experience in that area to become a care coordinator. Our behavioral health nurses must be at a minimum RNs with experience in the behavioral health field. We didn't mention that in the previous slide, but we have behavioral health nurses that will link our recipients to behavioral health programs or helping to make sure that the behavioral health and the medical services are integrated, that the community mental health centers know what is going on with their medical regime and vice versa. Our transitional care nurses must also be BSNs. By contract, the care coordination training has to include many different areas, including some of these here, which I think would be very important to your practice, such as person-centered care planning process, cultural diversity and competence, communication, abuse, neglect, and exploitation. I'm sure some of your recipients are in some difficult circumstances, and we need to make sure that we can identify those areas and make the proper referrals as needed. Medication management. Many of our health homes right now have training in specific diagnoses and helping them to understand what is needed for each of their recipients. And that is the end of the care coordination portion of our presentation today. I wanted to point out, and Drew mentioned earlier, that if you have any questions regarding the RCOs, the health homes, or anything that we discussed today, there is an email that you can go to directly, and those answers will be addressed, and we will reach out to you for those answers. And that is the RCO portal. That's RCO PORTAL at medicaid.alabama.gov. And you can see here also we have the website where you can find out all the information you could possibly want to know about the regional care organizations as well as the health homes. One of the things on that website is the contact information for each of our probationary RCOs as well as our health homes. If you have any questions about their program specifically, or if you want to sign a letter of intent or a contract with a health home, you can find that contact information on that website. Now I'm going to turn it over to Carolyn Byrne to see if we have any questions.
We do have some questions, and I want to thank all of you for this wonderful presentation. Peter asked, will each RCO be held to the same guidelines, standards, reimbursements, reports, templates, etc.? And I think this was coming from the fact that if there are multiple in these provider offices, have to manage, this.
Let me try to address some of that. They all will be subject to the same contract. So the same types of requirements will exist. Now, it may look a little different from RCO to RCO, but there will be the same types of requirements established in the contract.
Okay. And I think that we did have another question sort of addressing the same issue with the additional paperwork and the concern for that. So there were two questions that had the same relationship to that.
Right, and we may see some variation in terms of the paperwork requirements across the RCOs. Again, it's an implementation issue where we have to provide them flexibility. So there may be some differences. Now, the backdrop of that, though, is that these are locally led organizations. Physicians, pharmacists, optometrists, clients are represented on the boards of these organizations. So they have an opportunity to have an impact on policy and how things are implemented and how they're enacted. So I think that if there were a problematic area, then they have a venue. They have an opportunity to express that back to the RCO with folks on the board that might have an opportunity to have some sort of voice in how it gets addressed.
That's great. Thank you. We had another question from Kathy, and she asked, for rural health clinics, will nurse practitioners continue to bill under the clinic NPI? I don't know who the question should go to.
I'm not sure any one of us is necessarily the final expert on that, but
Okay.
we'll take that back and let's get a better answer to get a more definitive answer for you on that.
Okay, great. And then we also had Philip from a community mental health center who had joined us who has a question. He's asked, should community mental health centers partnering with RCOs to provide psychological and behavioral health services to Medicaid patients be expected to implement the risk stratification requirements under the care coordination portion of the RCO contract?
I'll take that one.
Okay, great.
The regional care organizations must do that risk stratification. It would not be the community mental health centers. They may partner with them to receive information to help them with that risk stratification. In care coordination, the risk stratification that each RCO comes up with depends, it's low, medium, and high, and depending on what the patient is at risk for, would determine how much care coordination they receive. But that is all the responsibility of the regional care organization. But they may partner as a multidisciplinary team with that community mental health center in providing services.
Thank you. And we just had another question come in, and I want to encourage the audience to either call in or send their questions. Ms. Patterson asked, can you give more explanation regarding HP and what that means? So we use the acronym.
My apology. AMA has a vendor, I'm sorry, Medicaid, my apologies, has a vendor who does their claims processing, and that's HP, who is Hewlett Packard. And so on one of the slides you saw that it was as HPE because they just done some rebranding, but it's essentially HP. So currently the way RHCs get reimbursed through the Medicaid agency is to submit claims to HP, and it's Hewlett Packard, and that's how the payment goes back out. It also comes from HP. So my apology that I didn't talk about that acronym.
Okay, and AMA was the Alabama Medicaid Agency. Okay,
yes.
Great.
Sorry.
Thank you.
Sorry, I'm so jargony. So.
One other question that we did have is for rural health clinics. Why? It was about the wraparound payment, and I think they needed more clarification on that. So is the wraparound payment going to be made to the RCOs, by the RCOs to the rural health clinics at the same time that their regular payment is made?
No.
Okay.
So it's the RHC will have to submit that claim twice. First, they will submit the claim to the RCO. The RCO will reimburse that claim per the physician fee schedule back to the RHC. The RHC will take that claim and enter into the new claim they're going to submit to HP or AMA the amount that they got paid, and that's going to be put in as a TPL amount, which is third-party liability. It says that just means I got paid from somebody else for this claim. So whenever it comes in, it's going to price at the current RHC price, the same price they're getting paid now. Okay. It's going to reduce the amount that's been paid previously by the RCO, and that's how that wraparound payment will work. Again, that's different than how other states do their wraparound payments. They do it in much more of an aggregate way, but this is a way that payment can go out much more quickly, and that's why we've decided to implement that. And this is a strategy that's been used by other states very successfully.
So it's a proven strategy?
Yes, ma'am.
Okay, great. We did have another question come in. This is from Tracy, and she said, will the RCO provide resources such as nutritionists, etc., for complex patients with conditions such as obesity? Or is the care coordinator more to track the number of patients with obesity? So I guess that's a care coordination.
I think it's going to depend on each RCO. I know with the health homes now, we have a health home program in the Huntsville region that decided with the funding they received to have nutritionists on staff. And so they actually have some that go to the home, they go to the physician's office to provide nutritional counseling for adults and children with obesity. Of course, that's not a service that is traditionally provided by Medicaid, but they saw it as a need. And so we may have regional care organizations going forward that may see that as a need. So I think it's going to vary from RCO to RCO. Wouldn't you agree, Dr. Moon?
I do. The only thing I would add is that now the RCO has a financial incentive to do those kinds of things in the sense that they would ultimately save them money down the road. So there is that opportunity. However, you could see variation from RCO to RCO in that regard. For services that are not already covered by Medicaid, you could see variation.
Right. And we do have a call that just came in. So Fort Payne, go ahead with your question.
Hi there, this is Dr. Peter Strogoff from 14 Pediatrics. This is a question. Hey, can you guys turn this off because there's a delay? This is a question for Jason Duhan regarding some billing.
Sure.
You know, currently we bill several different ways right now. So we bill to Medicaid as a rural health clinic, and most of those services are bundled. So really, we just bill a single code to them, 99211 with an SE modifier. Mm-hmm. That's our visit code for a sick visit. Right. And then we split off claims for services that we render that aren't in that bundle, such as labs. So if we do a flu test or a strep test, we actually split that claim off, and then we bill Medicaid directly. How is that going to work? And are you guys familiar with all the coding? The 99211 SEs, what is bundled and what isn't bundled? Have you guys given any thought to that?
Yeah, the answer is yes. Thank you for your question. The 99211 SE, that's the encounter claim that you bill or counter service that you bill, so that you get the kind of encounter payment. You're going to continue to bill that in a very similar way. It's just that would go over first to the RCO. The RCO is going to make a payment, and then once that payment is there, then you would resubmit it to AMA, and they're going to pay any differential that you did not get paid from the RCO.
So it's basically like a secondary claim.
Yeah, it's very much like it's very much like now if somebody had Blue Cross Blue Shield, you're going to bill Blue Cross Blue Shield first, take that payment, and then resubmit it to Medicaid afterwards to get any kind of differential.
Okay, and then the services, I guess, are we billing the RCO or are we billing the Medicaid directly for the services that aren't bundled into that visit? So again, the things that are bundled are like all the procedures that we do,
right.
Really most everything with the exception of lab.
You're going to bill all of the services that are covered under the RCO to the RCO. For example, something like a lab is covered, something like dental is not covered. I know many FQHC or RHCs will also provide dental services. The dental services you're going to bill directly to Medicaid for the services that are the covered services, and that was something that was earlier in the deck. And I think it's something also lives on the website as well. Those are going to be the ones you bill directly to the RCO, and then you submit it to Medicaid.
Okay, that's a whole lot more simple than it's been presented in the past, which is
great.
Yeah. Well, thank you so much, guys.
Thank you.
Thank you. And we do have another question from Ms. Woods, and this is an RCO question around transportation. Medicaid is currently using the NET program for recipient transportation. Will this process continue under the RCO?
There will be, our current plans are that there would be modifications to how we operate today, that the RCOs will be responsible for NET services for RCO clients. Now, how they choose to enact that, we may see some variation, likely will see some variation. But for RCO clients, RCOs will be responsible for providing net services.
And that could be different among each RCO. So.
There could be some variation. There will be minimum requirements, obviously, but there could be a variation in terms of how they choose to enact it.
Okay. Well, that takes care of our current questions right now, but I would encourage people to use the email address that's up on their screen to contact with any further questions. And we just appreciate so much your time and your expertise in bringing this information to our rural health clinics and other safety net providers. So we thank you so much.
Glad to do it. Thank you
I
very
have a
much.
question.
Thank you.
It's sort of a follow-up to the community mental health center question, but will the mental health centers need to screen their consumers for depression and suicide using a specific tool, like the PHQ-9, or is that going to be left up to each individual mental health center and RCO?
By contract with the RCOs, they will have to do a depression screening for adults. Currently, the health homes are using the PHQ-2 and the PHQ-9, and that will continue going forward. We didn't specifically indicate a depression screening for children. Of course, community mental health centers can do any type of screening that they feel is necessary, but that is an RCO requirement for anyone that is receiving care, any adult 18 and older that's receiving care coordination.
And we do have one more question. This is from Carol, and it's, how will recipient care be coordinated when a recipient changes from one RCO to another or moves from one area of the state to another? Will medical records be shared?
That is something we are currently working on. When a recipient moves from one region to the next region, obviously their RCO selection would change. They would go through the active selection again, and we would again let the RCO, the enrollment broker, know this recipient has moved and you need to outreach to them because they're going to make a new active selection to a new RCO. What we're working with the RCOs is Medicaid will be a kind of a central source of truth for all the claims and everything that recipient has received service-wise under the old RCO, so that when they get assigned to the new RCO could work with Medicaid to see what is their clinical history, what has been currently been going on, any PAs, any claims that have been processed, things like that, when they move over, because we do know there is going to be a big issue with the transitioning as our recipients move from one RCO to the other.
And let me just add to that. Whenever they do move from one RCO to another RCO, Medicaid will be sending out 3 years of claims history as well, so that information is known to the new RCO.
And there are contract requirements for the RCOs to smooth those kinds of transitions.
Thank you. And another question came in. This is a dental question. Will there be any thought to starting coverage for adults in reference to dental services? Because we do know in Alabama we have some challenges with our adult population getting access.
Sure. It's not really an RCO question. It's more of a Medicaid coverage issue and funding associated with Medicaid, and we'll take that under advisement. It's certainly something we don't ever forget about, and we have to continually think about. The issue would be funding.
Great. Well, thank you so much. That's all the questions we have, unless the audience has any questions. Well, we appreciate y'all's time, and thank you so much for being here.
Thank you.
Thank you very much.
Take care. And thank you all.